Welcome, everyone. Thank you so much for joining us. I am so excited to welcome you to our webinar, Barriers to Accessing Care for Women and Girls with Bleeding Disorders. I see that people are joining us right now, so from all over the world. So good morning, good afternoon, good evening, and thank you so much for taking your time to be with us today. My name is Dawn Rodolini, and I am your chair of the webinar today. I am the parent of a son with hemophilia. I'm a carrier. I do have symptoms of bleeding, and I do not have a diagnosis of having mild hemophilia. I'm the chair of the Women and Girls with Bleeding Disorders Committee, and I'm a WFH board member. I'm also the Chief Operating Officer of the National Hemophilia Foundation, and I've been with NHF in the United States for 13 years. I'm also a board member for WFH USA. But that is not why you're here. Why this webinar? So we all know this, and thank you again for joining us this morning and wherever you are in the world, but we know there are many unknown facts, misconceptions, taboos, and sexism around women and girls with bleeding disorders in general population, but also within the bleeding disorders community. This fact leads to lack of diagnosis, a reduced quality of life, more death amongst women, and a large gap in the data collection. In order to increase the standard of care for our whole community, the current situation of women and girls with bleeding disorders must be given particular attention. And to this effect, this webinar is aligned with the following WFH strategic priorities: identifying and diagnosing people living with bleeding disorders, and providing adequate access to care and treatment. Next slide, please. So a little bit of housekeeping, of course. We have live interpretation for you, and thank you to our interpreters for being here with us today. You can click on that icon, the little globe for interpretation. Please select your language of preference now. And then there's an option to mute the original English audio, and you'll see mute original audio. So that way you don't hear two things happening at the same time. Next slide, please. So for mobile phones, for those of you who are joining us from your phone, you'll see that on the bottom right, you'll see 3 dots to select the interpretation channel. You can also click, there might be a second step, and you can click done to select your language. Next slide, please. In order to ask a question today, which we really want to hear from you, please select the Q&A tab on the bottom of your screen and select the Q&A icon and type your question in. Please do that in the language of your choice, and we'll make sure that it is interpreted so that I can ask the question to our panelists and our speakers today. Next slide, please. So here is our agenda. Obviously, we're just doing our little housekeeping. We have a wonderful testimonial on late diagnosis from Yannick Collet from France. We'll hear from Dr. Michelle Lavin from Ireland on the lack of data, late diagnosis, and sexism and bleeding disorders. We'll hear a testimonial on severe von Willebrand disease and taboos from Fozia Parveen from Pakistan. We'll hear from Dr. Roshni Kulkarni from the United States on transcultural issues and taboo topics for women and girls with bleeding disorders. We will learn more about the WFH World Bleeding Disorders Registry and the opportunities for data collection, which I pointed out is so critical to getting access to diagnosis and treatment, from Emily Ayub from Canada. And then we'll hear from Elizabeth Kampur from Latvia and Anne-Louise Cruikshank from South Africa on getting access and the importance of the role of an OBGYN, nurses, and midwives in women and girls with bleeding disorders healthcare. And then we'll have a chance to ask questions to all of our panelists and our speakers today. So I would like to go to the next slide, please. A little brief moment about our speakers. I really don't want to take a ton of time here because we have so much content to get to today. But I will start with Emily. Emily holds a doctorate degree in biochemistry from McGill University. She's the data and research manager at the World Federation of Hemophilia, and she manages the World Bleeding Disorders Registry and related programs and initiatives. She has spent 9 years in academia as a cancer researcher and an academic development officer. And Emily is critical to working along with innovative programs alongside patient partners and conducting national needs assessment studies and advocating for patients living with incurable cancers. Dr. Roshni Kulkarni is Professor Emerita of Pediatrics and Human Development and Director Emerita of the Michigan State University Center for Bleeding and Clotting Disorders, board certified in pediatrics and pediatric hematology and oncology here in the United States. She's also a founding member of the Foundation for Women and Girls with Blood Disorders. She's a member of our Women and Girls with Bleeding Disorders Committee, and we couldn't do the work that we're doing without her help. Dr. Michelle Lavin is from Ireland, as I said. She's a consultant hematologist in the National Coagulation Center at St. James Hospital. She's also a researcher for the Irish Center for Vascular Biology in Dublin. Her research focuses are on improving diagnosis and care for women and girls with bleeding disorders and understanding the pathophysiology of bleeding disorders. She's the chair of the World Federation of Hemophilia, VWD, and Rare Bleeding Disorder Committee, and also co-chair of the European Association of Hemophilia and Allied Disorders for Women and Girls with Bleeding Disorders. Dr. Elizabeth Pampour is an obstetrician gynecologist and also a lecturer in Riga Stratens University in Latvia. As a trainee, she was very actively involved in European and World Association for Trainees in Obstetrics and Gynecology. And she's very enthusiastic about improving quality of care for women as well as educating women about their health. We're really excited to have her here with us today. She pays attention to abnormal bleeding patterns in women and refers them to hematologist Elizabeth in helping identify numerous cases of bleeding disorders. Anne-Louise Cruikshank is a nurse and a midwife. Anne-Louise, thank you for being here with us. For the past 21 years, she's been at the University of Cape Town, based in Groote Schuur Hospital. Anne-Louise coordinates comprehensive care for patients with bleeding disorders, hemophilia, and in the Western Cape province, including implementing and coordinating a national outreach program. So that is an overview of our speakers. Let's go to the next slide, please. So we want to start with this testimonial from Yannick Collet, and let's take it away.
Hello, my name is Yannick Collet. I'm 59 and I'm living in the south of France. I'm living with my hemophilia A. My situation as a woman with bleeding disorders wasn't recognized for a long period, and my symptoms occurred: bleeding after tooth extraction, nosebleeds, bruises, heavy menstrual bleedings. Each time the same answer: it's impossible. A girl, a woman doesn't bleed. Only men are affected by hemophilia. As I become older, the main symptoms, heavy menstrual bleedings, have been normalized by my contraception treatment. By aging, problems came back. I stopped hormonal treatment because I decided to have a tubal ligation, and heavy menstrual bleedings came back. They became worse because of fibroids. I went to the gynecologist and he decided to do an hysterectomy. I must advocate a lot to access analysis before this surgery. I decided on my own to go to the HTC and ask a hematologist. At 46 years old, the diagnosis was done. As a carrier of hemophilia A, I have a low level of factor VIII. I have only 30%, which explains why I had so many bleeding troubles for years. I am affected by mild hemophilia. I need treatment in case of accident, a surgery. Now it's recognized. 1/3 of carriers of hemophilia A or B have bleeding episodes. They are hemophiliacs. Was the hysterectomy the only solution for my heavy menstrual bleedings? Why has any treatment been proposed at first? Now I have to face many other problems because of that surgery. I discovered that only at 46. My life would have been different by knowing that before. Now I want to fight against this lack of knowledge, the late diagnosis, and give access to treatment, care, and support for all girls and women with bleeding disorders. I don't wish any women to live these years of wandering.
Thank you so much, Yannick, for sharing your story with us. It is so important for us to hear from each other and to learn from each other, and that together we can advocate for better diagnosis and treatment. So next, I would love to welcome Dr. Michelle Lavin on the lack of data, late diagnosis, and sexism and bleeding disorders. And I want to thank Dr. Lavin, who unfortunately couldn't be with us today, but she pre-recorded her session so that we could really have this perspective. So thank you so much. Please play the video.
Thank you for this opportunity to present on a topic I think is deeply important: the lack of data, the late diagnosis, and the sexism that can exist in the field of bleeding disorders. Here are my disclosures. As an additional disclosure, throughout this talk I will refer to women and girls with bleeding disorders, but I do not mean this to be an exclusive term, and this should include those individuals who retain the ability to menstruate, such as trans men. I think it's important just to acknowledge for a moment that they may have significant additional challenges, as do trans women, but that's outside of the scope of this talk today. So, diagnoses are often delayed in women and girls with bleeding disorders. For example, although women can obviously have hemophilia, and it's recognised that carriers may exhibit bleeding even with normal levels, for those women with moderate and severe hemophilia, they are classically diagnosed at a much later stage, with delays in diagnosis of 6.5 months in those with severe hemophilia in comparison to men, and 39 months in comparison to men with moderate hemophilia. It's not exclusive to hemophilia in that those children diagnosed with von Willebrand's disease, at the age of 10, 76% of males will be diagnosed, but only 50% of females. And in the adult setting, we frequently see the patient journey has been a prolonged and often torturous one to diagnosis, with an average of 16 years between symptom onset and diagnosis, and many women presenting to multiple different healthcare providers with discrete and different bleeding symptoms before somebody considers a referral for a hemostatic workup. So why are these delays present? Well, there was a really provocative and interesting article by Angela Wayland just last year, and it highlighted the fact that there is undoubtedly sexism in our bleeding disorders. And this comes from many different aspects. Not only is the most common bleeding symptom amongst women and girls with bleeding disorders heavy menstrual bleeding, menstruation itself is stigmatized, but also both patients and providers are unaware what constitutes a normal period. Many of these conditions are hereditary and familial, so that not only is that individual person's idea of what a normal period disrupted or changed, but when they seek advice from their other female family members who could be also affected with a bleeding disorder, they're often falsely reassured that this heavy bleeding is to be expected and part of normal life. Similarly, physicians may falsely reassure women that their heavy periods are normal, or may fail to further ask women questions pertinent about their bleeding history if they describe their periods themselves as being fine. Cumulatively, this results in an under-recognition of bleeding disorders in women, and more resources are continuing to be devoted to the men who are attending our centres, which further really aligns the centres towards that direction of care. So clearly we have issues in both society and also in the medical environment about recognition of abnormal bleeding. Sometimes people may be quite concerned about symptoms which ultimately prove to be quite minor, but the converse is most commonly true in our setting, where people can normalize extreme or heavy bleeding. This leads to a failure to refer and a delay in diagnosis. And because your phenotype or your bleeding history is what drives the need for testing, if we can't assess and diagnose and determine the level of bleeding correctly, then you may not get further testing performed, even when it's appropriate. And when we think about the traditional role of our haemophilia treatment centres, even if you get as far as a diagnosis, well, the HTCs have built up around this hugely important condition, haemophilia. And we have a lot to thank our haemophilia colleagues and the people who have driven these paths for us, because we have this fantastic network of treatment centres for people with bleeding disorders. But it's important to acknowledge that these have come from a historical basis of provision of care to men with haemophilia. And now we need to transition to a more equitable approach where we provide care equally and equitably to all people with bleeding disorders. So what about if you are a woman with haemophilia or a haemophilia carrier? How is your care currently focused? I think this is a really good example of perhaps how we're continuing to have an unconscious bias towards women and disenfranchise our female patients. But when we think about the focus of care for carriers, it's really largely about pregnancy management. If you're a known carrier, that's when your centre wants to see you. And we often focus so much on the pregnancy because we're really wondering, is there a male infant who could be affected with the haemophilia? So you determine the factor levels in the mother. You can do genetic testing or prenatal diagnosis, PND, to determine if there's an affected male infant. If you have a boy, you're going to get cord bloods performed and factor levels. And those boys will be followed up in the long term if their levels are reduced, because they now are a new diagnosis of haemophilia. But too often I worry about the girls. Not only are we focusing on the mother as being a carrier of haemophilia rather than an individual who could bleed herself, we're also risk disenfranchising the second generation of females who could be carriers, because there may not be a standardized approach to cord bloods in female infants, or to long-term follow-up if they are reduced. And if they're normal, if those cord blood levels are normal, is that individual guaranteed follow-up at the haemophilia treatment centre? And is there a standardized way to link them in to determine their carriership when they're, in our setting, you'll be 16 before you have genetic counselling performed? So we really need to step back and look at what we're doing. You know, do we routinely take a bleeding history in our women who are attending? What advice are we giving them regarding their primary postpartum hemorrhage risk? How do we counsel women regarding the bleeding they can experience, which can be normal after delivery, called lochia, but if it's excessive or heavy, it forms a secondary postpartum hemorrhage? Do they know to attend us? Do they know when to seek help? What follow-up are we offering women? So we need a more inclusive approach for women in this setting. And it's clear that even beyond this setting, women face many challenges in their care. The medical management is often skewed towards the males in the centre. I often ask my colleagues at conferences, you know, where is their factor concentrate? Do they know where they have ice, or how they can contact their physio if a man comes in with a hemarthrosis? And universally, everyone has a clear protocol or plan for this. And then I ask, where are the sanitary pads kept in your centre? And often people just don't know. So the most common presentation is going to be acute heavy menstrual bleeding in a woman, but we're not really set up in the same way we are for the men who present with bleeding. And in terms of the treatments we use, it's well defined that there are gender-specific differences in the pharmacokinetics and pharmacodynamics of medications, so how your body processes and uses medications. But if you look at research on haemophilia treatments, it's largely focused on men. And we assume equivalency in female, despite these clear gender-specific differences. And in terms of the current interventional clinical trials recruiting for haemophilia, There was 60 trials, but only 20 allowed recruitment of females, despite the fact that females may be affected with this condition. So if you're not in at the very beginning and involved in research, how can we design the best care for you? So change needs to really start at the very beginning, not only in research, but even back further than that, at medical care. So we continue to teach this idea that women are carriers of haemophilia and unaffected. And this reinforces the idea that women do not bleed, not only in the setting of haemophilia, but also colours our viewpoint when we have women presenting with other bleeding symptoms. So we need to encourage not only medical change, but also societal change, where there's a wider acceptance of talking about abnormal bleeding, particularly heavy menstrual bleeding or bleeding after delivery, postpartum hemorrhage. So in order to try and really engage with younger people and to inform, we have a number of initiatives, including this knowyourflow.ie, trying to inform people about what is a bleeding disorder and what are the signs, and thinking about simple messaging to try and open the conversation around heavy menstrual bleeding. But what about the individual women and girls that are currently attending us? What do you know about the impact of these barriers on their lives? Well, I was very fortunate to work with the EAHC on this survey of women living with bleeding disorders in Europe. And it really focused for the first time on the physical and emotional impact of a bleeding disorder. And we found that there's many general bleeding symptoms experienced by women and girls with bleeding disorders. Probably not surprising to see things like nosebleeds are higher in the girls with von Willebrand's disease and in haemophilia. But what was surprising to us was actually the rate of joint and muscle bleeds. So you can see that here, ranging from about 3% in carriers with classified as normal levels to 6% in carriers with less than 40%, and higher again, 13% in those with von Willebrand's disease. And we think of joint and muscle bleeds as a classical male symptom. I think this highlights that it can occur in women, and we're probably not as aware of that or are prepared for that in our centres than we should be. And we need to understand and to recognise the impact of having a bleeding disorder on physical and reproductive life. So this question asks people about the impact on their physical life, where the lower part of the bar refers to the least impact and the higher parts the most impact. So you can see about 30% of carriers described an impact on their physical life, with about 60% of women with von Willebrand's disease describing an impact that was towards the higher end of the scale, 3 out of 5 or above. But certainly what I found quite shocking was the impact on reproductive life. So this altered their decision-making regarding having further children or making the decision to have children. And we found that 60% of women scored 3 out of 5 or above in this category. So clearly there is a bigger impact on people's reproductive choices, and this may be framed by previous negative bleeding experiences or the concern of passing on this bleeding disorder to their children. And I think this underscores the importance of multidisciplinary team approach, including psychological help and support, so that women can face these challenges and with a bit more certainty, information, and hopefully in a more positive light. So how do we evolve and improve care for women and girls with bleeding disorders? Well, I think this is the key message. If you're not registered, you're not recognised. So throughout the world, health systems are under-resourced and have to fight for resources with other conditions. And what drives funding in many situations is information and data. And if you are not registering girls and women with bleeding disorders, then they are invisible to the healthcare systems that we work in. And this has long been, a failing of us all internationally that we really need to remedy. And I'm so thankful to the World Fed for actually focusing and highlighting and underscoring the importance of this. But if you don't register and you're not registered nationally and internationally, then nobody can see the scale of this problem. And well, why aren't we registering, or are we registering? Why do I even say this? Well, if you look at the World Federation data, which is some of the best data sets internationally, you can see that there's only between 3 and 5% of those with haemophilia are female. Now, you may say there will be always more men than women affected with haemophilia, and that's true. But for every single one of these people living with haemophilia, these men living with haemophilia, they have a mother, they probably have sisters. We know that there's 1.6 carriers for every man with haemophilia, and 30% of them will have reduced levels. So where are these women? They're not represented, they're not visible, and it's very difficult to leverage funding and resources for a problem that nobody can see. I think then we need to look at the people who are already registered in our centres, and we need to aim high. We need to be doing better and standardising care. And in keeping with this, the European Association of Haemophilia and Allied Disorders and the European Patient Organisation, the Hemophilia Consortium, have worked together on principles of care for women and girls with bleeding disorders to try and really set the bar high and tell our centres what we expect of them to provide for their women and girls with haemophilia. Haemophilia and of course any bleeding disorder. And I think then we can't move forward without research. But research in its current format has been really designed towards men with haemophilia and not women with other bleeding disorders. So we need female-specific outcomes that can be used and standardised across multiple studies, so we can see if different treatments have an improvement in heavy menstrual bleeding, or if there's differences between different bleeding disorders using the same outcome measures. So how do we improve care as a summary? I think we need to move away from, the trajectory of care in the past, which has been largely towards men. We need to reevaluate how we're assessing women, understanding bleeding, taking menstrual histories, and how we provide care within our centres. We need to recognise that it's not just about pregnancy care and management, that there are individuals who experience bleeding, and we need to focus care not only on having a healthy pregnancy, but throughout their whole lives. We also need to work on increasing recognition and diagnosis at an earlier age, so that women can be diagnosed either pre-menarche or as they experience their first periods, and can be supported appropriately during what is often a turbulent time for them. We need to work on registration. Every country should be registering their women and girls with bleeding disorders, so we can understand and appreciate the scale of this problem locally and internationally, and dedicate resources and funding towards it appropriately. And finally, we need to work on research. We need to have research that's designed with our female patients for our women and girls with bleeding disorders, and we need to standardise our patient-specific outcomes in order to address the deficits that currently exist. Thank you.
Thank you so much, Dr. Levin. Okay, it's the 4 R's, everyone. Reevaluate, recognition, registration, and research. That was an outstanding presentation. I just learned so much. So next we will hear from Fozia Parveen. It's our second testimonial today, and it is her story from Pakistan. Thank you so much, Fozia, for sharing your story with us.
बिस्मिल्लाहिर्रहमानिर्रहीम अस्सलाम वालेकुम। मेरा नाम फौजिया परवीन है और मैं वॉन विली ब्रंट डिजीज़ की पेशेंट हूँ। मेरी एज 43 है और मुझे टाइप 3 स्वेयर है। चूँकि मेरे भाई का पहले ही इंतकाल हो चुका था, इसलिए मेरी डायग्नोज जो है वो 2 माह में ही हो गया था। जब मैंने स्कूल जाना शुरू किया तो मुझे बहुत से मसाइल का सामना करना पड़ा, और जब मेरी ब्लीडिंग होती थी तो मुझे छुट्टियां करनी पड़ती थी, लेकिन फिर भी मैंने अपनी स्टडीज़ को जारी रखा, मैं रुकी नहीं। और जब भी मुझे ब्लीड होती, मसला होता तो मुझे हॉस्पिटल में एडमिट होना पड़ता था। मुझे बहुत ज़्यादा ब्लड लगता था, तो उस वक्त तो फैक्टर्स का इतना नहीं था, फैक्टर्स मौजूद नहीं थे। लेकिन एक दिन मैंने टेलीविज़न पर हीमोफीलिया पेशेंट वेलफेयर सोसाइटी के बारे में एक प्रोग्राम देखा, तो फिर मैंने अपनी रजिस्ट्रेशन हीमोफीलिया पेशेंट वेलफेयर सोसाइटी में करवाई। इसके अलावा लड़कियों के लिए मेन मसला जो शादी का होता है, पहले तो मुझे पता ही नहीं था कि ऐसी पेशेंट्स की शादी भी मुमकिन है, लेकिन जब सोसाइटी के ज़रिए थोड़ी अवेयरनेस हुई तो फिर पता चला शादी मुमकिन है, तो इरादा बना। तो पहले तो मेरे घर वालों ने इसकी चीज़ की मुखालफत की, उनका नहीं इरादा बन रहा था। लेकिन फिर हमारे माशरे की सोच भी कुछ इस तरह की है कि जब उन्हें हम इस बीमारी के बारे में बताते हैं तो वो इस चीज़ से अवॉइड करते हैं, इनकार कर देते थे, तो जिससे मुझे बहुत ज़्यादा ज़हनी अजियत का मैं शिकार हो जाती। लड़कियों के लिए जो ज़्यादा मसाइल हैं वो अखराजात उठाने के हैं कि उनके अखराजात कौन उठाएगा। मुझे घर से अकेले भी आने जाने की इजाज़त नहीं होती, तो कोई भाई या फादर या कोई बंदा होगा जो मुझे साथ लेके जाएगा। इसमें मुझे फिर प्रॉब्लम होती है कि किसी के पास टाइम होगा, वो फारिग होगा तो फिर मुझे लेके जाएगा। हीमोफीलिया पेशेंट वेलफेयर सोसाइटी के लिए फ़ंड रेजिंग करती हूँ। मेरी कोशिश होती है जहाँ तक मुमकिन हो सके मैं उनके लिए फ़ंड रेजिंग करूँ, उनके लिए हेल्प करूँ ताकि इलाज में उनको मदद की जाए। हीमोफीलिया पेशेंट वेलफेयर सोसाइटी में ख़वातीन के लिए, उनकी बेहतरी के लिए, उन्हें बाशऊर बनाने के लिए और उन्हें बाएमाद बनाने के लिए उनकी मदद करती हूँ, उनके लिए काम करती हूँ। थैंक यू।
Fawzia, thank you so much for sharing how the impact of living with a bleeding disorder in Pakistan has affected you, and you're just such an inspiration. And speaking of inspirations, now I am so excited to welcome Dr. Roshni Kulkarni, another member, as I said earlier, with our Women and Girls with Bleeding Disorders Committee. Roshni, the floor is yours.
Thank you very much, and thank you to all for attending. And I am just delighted to present this. So the topic I'm going to present today is not your run-of-the-mill, how do you diagnose and what do you do and all that, but what are the barriers? You know, one of the biggest barriers you just heard from Fawzia before is culture. And there are all kinds of taboos. People don't talk about it. And so when you want to register a patient for, you know, the World Federation or something like that, culture and barriers and taboos are one of the biggest barriers we have to face. Next slide. So I don't have any conflict as far as this topic is concerned. Next slide. So what is meant by taboo? What is meant by culture and transcultural issues, cultural competence, and cultural awareness? And how do these impact menstruating women, pregnancy, delivery, and something we don't really think about, body modification and tattoos. A lot of our women get tattoos, and if you have a bleeding disorder, just think about it. So one has to talk about overcoming barriers of taboos, language, culture through outreach and digital technologies and social media. I'll just very briefly mention. The next slide. So what is a taboo? A taboo is a social or religious custom prohibiting or forbidding discussion. So you can see the lips are zipped. So it comes from the Polynesian word called tapu or tafu, which is associated with avoidance of certain things like people, places, objects, food. So the most common type of taboo is cultural, religious, or food. And just to give you some examples, many cultures, it is considered inappropriate to discuss menstruation, to discuss sex, or premarital sex, or gender or sexual orientation, like, you know, discussing transgender people. And another type of taboo is religious. So these are forbidden by religion. So there are menstrual restriction placed. Food taboos, you know, eat this, don't eat this, don't eat pork, don't eat fish, you know, don't eat meat on certain days and things like that. So these are very common. And, you know, you have to break a taboo in order to reach the woman and help her out. The next slide shows that culture, on the other hand, what is culture? It's all ways of life, defining art, beliefs, you know, in the population, and it's passed from generation to generation. We all know that this is in my culture. The problem now, it's really not a problem, it's a great thing, is that the world is becoming a mixed place. So their current, you know, clinical practice is globalized because of immigration. So I have to know not about my own culture as a physician in a different country other than my country of birth, but there are people who are born and their children are born and they're a mixture of cultures and society. So transcultural means being sensitive to and aware of cultural differences. And the healthcare providers need to be familiar with these. And, you know, culture involves cultural competence. That means you know what it is the ability to understand and appreciate and interact with people from different cultures. And it includes like language, communication. I'll just give you an example. For example, in India, there are different ways of saying yes. So people do like this, yes, people do like this, yes. So other people get confused, like, is this yes or is this yes? So you have to know that, yeah, that's okay. There are different ways of communicating that information. And the goal is to provide culturally sensitive and medically appropriate therapies. Next slide. So let's talk a little bit about menstrual period myths and, you know, culture. The word menses is derived from the Latin word month and Greek word moon. And it synchronizes, it's like periods are like 28 days, and that synchronizes with the moon and wide cosmic, you know, cosmic rhythm. And there's a belief that the universe may descend into chaos. Oh my God, we women are so powerful. Forget about all these space shuttles and all going. We, through our menstrual period, can control the universe. Just think about it. So in many cultures, it's considered that it can heal the sick. It has the power to destroy enemies. It scares away hailstorm. Wouldn't that be nice if we can get rid of all the hurricanes just with menstruation? And menstrual period is dangerous to men's power. So that's why there's such a myth and, you know, all these stories surrounding cultures. And next slide. So many consider menstruation a gift from God, a punishment. Is it sacred, magical, powerful? Is there a fear of blood? And you heard of the word hysteria, hysterectomy, okay? That's very interesting. Hysteria means it's erratic behavior due to menses and accumulation of blood around the heart and a wandering uterus. I thought that was so funny. So hysterectomy, you remove that wandering uterus from your heart and the person becomes normal again. And many people consider that menstruating women, you know, pollute holy places. So there are cultural problems, mythology, religion, and politics, you know, and even in this country, the recent Supreme Court ruling and all focused on uterus and women. Give me a break. All right. So the next slide shows we need to know what are menstrual periods called. You know, think about it. Go back to your own country and say, what do you call menstrual period? And I love this. Australia, it's called Shark Week. If you have menstrual period and you go in the ocean, all the sharks come and attack you. And you get Shark Week panties, saying you can read, this is, you know, help yourself to Shark Week. And then big ant is coming or chums. So when you talk to girls, especially, you have to talk their language. So if you say menstrual period, they will say, well, what is that? Oh, have you had your chums? Or 3 days? You know, just think, we think 7 days is okay, but 3 days, you know, is like, that's what it's called. So you need to be aware of all these terms. The next slide shows that menstrual period affects all aspects of a girl's life. And this particular slide is from the African country. It's called AFO. And it can affect education because girls may miss, and you heard that person talking about how she had to go to school And, I really admire her that she went to school and got a degree. But many girls miss education. As a result, they accept jobs that they are paid very little. And recently there was a news media at NPR News that in some parts of India, women deliberately undergo hysterectomy because menstruation affects their daily living wages. They can't work in a mine and miss, during the periods, they miss the daily wages, and that affects their income. So it has an economic issue, then of course, dignity, health, and participation. So I've just written down all the stigma, the shaming, menstrual ostracization. That means you separate, you keep that person in a hut or a different place. And, and that causes mental health issues such as anxiety, depression. And, poor girls, just think if a girl has a bleeding disorder, all this is magnified 10 times. So we have to help these women and girls by understanding. The next slide shows that in many cultures and many countries, menstruation, reproductive tract bleeding are taboo topics. I'll just give you my own example. When I first came to United States, I came to Denver, Colorado from India. And as it happens, I had my periods at that time. And I wanted to get sanitary napkins. And my brother was picking me up. There was no way I was going to talk to a man about my menstrual period. And here I'm a doctor. So I said, I need to go to the pharmacy. And he said, what for? I said, what to buy toothpaste? He said, I have enough toothpaste. I said, no, I need toothbrush. And he said, I have enough toothbrush. And I'm like, oh my God, oh no, I need to buy some medicines. I was just skirting around the issue. And he said, can you tell me what's wrong? I said, no, I need pads. He said, why didn't you say so? So, even talking about it was terrible for me. And I remember that day. So there is stigmatization that leads to decreased awareness, contraception medications. And currently we call contraceptives hormonal therapy because in United States, the big thing is about abortion and all. So we don't even want to talk about that. We just say you are getting hormonal therapy. And then many women have a gender preference. They like male physicians. And there aren't that many women physicians to go around. So sometimes, they get overlooked. And then many times special diets influence bleeding, like garlic and things like that. Traditional remedies such as cupping for menstrual pain, acupuncture, et cetera, may affect bleeding tendency. And then I'm going to talk a little bit more about the ritual of body art and body modification. So the next slide shows, this is a very nice article from Iran, and it reflects what Fauzia said. Iran has high rates of both Glanzmann's thrombocythemia, which is a platelet disorder, and other kinds of bleeding disorders. And they have high rates of consanguinity. And they're deeply affected. So they have difficulty in getting married. And that's exactly what Fauzia said, that nobody would even look at her. In my practice, I have seen fathers saying they will test the boys, but will not test the girls, because who will marry her? And so the disorder is kept a secret. And as a result, many of them experience profound emotional distress and are reluctant to discuss intimate matters. And you have, as a healthcare provider, you have to gain their trust. The next slide shows that many religions affect menstrual issues. In many religions, women are considered unclean, untouchable, and are impure in many countries. And so women are often banned, but on the other hand, in some places they're worshipped, and in other places they're exiled. So the next slide shows, and this is in India, in the South India, there is a temple, Sabarimala temple, where menstruating women are not allowed. The Supreme Court ruled that that was a violation, but that practice still persists. On the other hand, in North India, there is a menstruating goddess. And if you go to the inner sanctum, the shape of the inner sanctum is like the woman's external genitalia. So on one hand, they're banned. On the other hand, they're worshipped. So this is very confusing. And I think all these are imposed by people. The next slide shows that in some places they're exiled. They're asked to go to a hut. And they're called chaupadi in Nepal. But in other countries, Ethiopia, they're called margam. In Colombia, Australia, West Africa. And the problem is when you exile or isolate a woman in this little hut, and it's very cold at times. So there have been deaths due to diarrhea, dehydration, smoke inhalation, because to keep warm, they burn wood and all and can die from carbon monoxide poisoning, snake bites. And again, you can see that there have been many reports of, and it's banned in Nepal by the government, but it's still practiced in remote areas. And the next slide is other places. You have puberty party or half sari function. So in India, people wear a sari, but when a girl starts attaining menarche or menstrual period, they wear what is called a half sari. They have a part of a skirt and a drape that covers their developing breasts. And so that's a sign of, that the girl has attained menarche and is ready for marriage. There's bat mitzvah in the Jewish religion. And this is my experience with menstrual isolation, is my mother, when she went to the village and was menstruating, was kept in a room and I wasn't allowed to touch her because, she had to be in isolation. In some ways that was good because she rests from all the household duties, but in some ways it's very confusing to her children who are not able to touch her. The next slide shows that these cultural practices even extend to pregnancy. In many, many countries, home births are preferred to hospitalization and medical intervention. And my own aunt, my dad's sister, died from postpartum hemorrhage in a village, in a little place surrounded by other women who really could not help her. And WHO estimates 800 women die every day. Every day, remember, that is 800 women from pregnancy or childbirth related complications. In 2017, 295 women died following childbirth. And what is the most common cause? Bleeding. Even in this country, a recent CDC report showed that women are still dying. I'm not saying that all of them have a bleeding disorder, but if they have a bleeding disorder, we should diagnose them and help them. So the next slide.
Roshni, just a time check. We've got 2 minutes.
Okay. So a lot of cultures include burying the placenta, restricted diet, etc. And in Pakistan, and in some parts of it, bleeding is considered healthy. And the next slide shows a woman with hemophilia in Japan sobbing because of her experience with postpartum bleeding, and sisters deciding to forego marriage, as I'd explained before. And the next slide shows the body art. So tattoo is a very common practice. And many of these women bleed with tattoo. And should we be giving them factor or prophylaxis before they get a tattoo? So please ask these women who get tattoo and all, do you have an underlying bleeding disorder? The extreme form of body modification is female genital mutilation. The next slide, and I'm not going to go into detail about it. It is basically removal of the external genitalia of women with a razor blade. And it is practiced in many parts of the world. It has absolutely no health benefit and it causes severe bleeding. So please be aware of this. That's all I'm trying to bring. And if you're a woman or a girl with a bleeding disorder, you can pretty much bleed to death or have heavy bleeding. And the next slide just shows that we need to use the social media. And amazingly, girls nowadays are doing that, end menstruation stigma, happy to bleed, period poverty and all that, and free menstrual products. So we are coming there slowly, but we should encourage this more and more. And the next slide, I think, is my last one. And I want to acknowledge the World Federation, the Hemophilia Foundation of Michigan, foundation of this thing, and of course, my institution. Thank you.
Dr. Kulkarni, thank you so very much for your presentation. Boy, it just evokes so many questions and challenges and sometimes outrage. So thank you very much. Sure. Our next presenter, thank you, Emily, for joining us. I'm happy to welcome you. Emily is the Data and Research Manager at WFH, and she's going to talk to us about solutions and ways in which we can start to overcome the barriers faced by women and girls with bleeding disorders. Emily, take it away.
Thank you, Dawn. Thank you all for being here with us today for this very important topic. I'm very pleased to share my presentation on a subject that is we're very passionate about at WFH, which is data collection. So I will be talking to you about our World Bleeding Disorders Registry. It's a WFH registry, and how we can use this registry to remedy the gaps in data that would allow us ultimately to improve the situation in women and girls with bleeding disorders. Next slide, please. So if we think about diseases in general, and we look at where investment goes, where research goes, where the focus is, it will be on diseases that are more common, that are more, that have higher mortality rates. So for instance, cancer, cardiovascular disease are of a big focus. So their focus is always on the more common. Next. Now let's take bleeding disorders represented here by the red dot. And this is just for illustration purposes. The proportions aren't to be taken as numbers here. So looking at the bleeding disorders now, which are a rare diseases, and looking at the population affected, as you all know, the focus is on males because they are the majority of the patients out there, especially in hemophilia, for example. And women are the less common. Next, please. So we all agree that we need to focus on women and we need to focus on the few. I'm calling them the few, but that doesn't mean they don't exist. This is exactly why we're here today. So focusing on the few starts by identifying the few. And I guess this reflects a bit what Michelle was talking about. We can understand what is going on without identifying the people who are suffering. So I'm showing here an illustration. It's a graph from the annual global survey from WFH, showing over time how we were able to identify more and more people with bleeding disorders. And so it's feasible to improve identification. Next slide, please. So then now you identified the few. The next step is to learn about them, to explore their condition. What are their symptoms? How can we improve that? So let's consider the example of males with hemophilia. Let's consider them more for a second and look at this timeline, the historic timeline of different discoveries in the fields of hemophilia. Most of these, as Michelle stressed out, the research has been done on male subjects. But over time, it was a success because now we're in the golden era where, therapies are very innovative and more effective. So going through the learning experience about this disease through the male lens has improved their condition. Next slide, please. So we learned about it, and then we were able to discover treatments. We started in the 1920s with icing, splinting, bed rest, and now we talk about gene therapy, extended half-life, factor 8 and 9, and other non-replacement therapies, for instance. So we've come a long way, again, focused on males, but nonetheless, we can all agree that evidence, research, data driven these discoveries, these important discoveries. Next slide, please. So I'd like to think of data like water. It's a very simple analogy, but it's an effective one, I think. So data are essential, like water. They are needed in order to make informed decision, whether it's in a clinical setting, whether it is at the procurement level. They are needed in order to address the situation in adequate fashion. But data need to be accessible. You can have water, but if you can't access it, you can't drink water. So accessibility of data needs to be, or key stakeholders need to access it. For instance, doctors need to have the full information on the patient in order to make a better judgment and a clinical decision. Governments need to know how many patients they have and what kind of treatment is needed, how much consumption there is in order to do better procurement and procure the correct drugs. Advocates need data in order to actually show evidence of the situation at hand and advocate for better access. And the data, most of all, has to be clean, right? If the data is unreliable, it cannot be used. So I guess this is stating the obvious. Next slide, please. So we believe that the WFH World Bleeding Disorders Registry addresses, or maybe offers the opportunity to address these three main pillars of data. It provides the data that is essential. So the data are collected are essential for different decision-making. The data are accessible. And importantly, they are reliable. They're collected in a standardized way. And we do data cleanups and data quality so the data can be used by different stakeholders. So in 2018, this registry was launched. It is now the only global registry collecting standardized clinical data on people with hemophilia. And soon we're adding von Willebrand disease from all around the world. Next slide. Just to give you a snapshot of where we're at in terms of enrollment. So at the moment, we have 112 HTCs in 43 countries enrolling people with hemophilia and hopefully soon with von Willebrand disease. We've enrolled over 10,000 patients to date. And so we're happy with how the registry is growing. We have a lot of data that is very, very valuable. Next slide. So the type of data we collect and how this can relate to people living with bleeding disorders and specifically women, since it's the topic of today. So we look at the different information such as the demographics. I would like to thank Fozia and Yannick for their testimonial because they did speak about how this affected their life, their education, marital status, reproductive decisions, because we do collect these data and the WBDR, so these data can be used to showcase the scale of these issues. We look at diagnosis, different clinical histories, and we look at the clinical experience, the clinical aspects such as the bleeding events and different body parts, joints, the treatment, inhibitors, hospitalization, quality of life, and among many, many others. So all these data on women and girls will be of extreme value. Next slide, please. However, we need to do more. As an organization, we have set as part of our strategic priority mentioned previously in the webinar, we would like to focus on enrolling more women and girls. So if you look at these slides, and my apologies, the numbers are small, but you can appreciate that the majority of the patients that are enrolled in the WBDR at the moment are males. And this is not surprising, unfortunately. And the females are about 0.7%, whether it's hemophilia A or B. This is actually something that we are currently working on. We're doing more education, outreach. We're talking to our centers to encourage them. But it's a multi-tiered problem that requires a multi-tiered solution. So in addition, we're working with our colleagues at WFH who work on the Women and Girls Initiative in order to have this more 360 intervention to improve this. Next slide. So we're additionally collecting data that are more specific to women and girls. For example, heavy menstrual bleeding, so the centers can collect these data accurately. We also collect data on, we will be collecting data on pregnancy and postpartum hemorrhages, comorbidities such as endometriosis, and hospitalization related to specific complications that female can face. Next slide, please. So I'm not going to go over the details of this slide. You know, the registry, patient registry has a lot of benefits, and many of which, if not all, are of benefits to women. We can talk about facilitating research. So these data collected through the registry can help facilitate research on women issues. We talk about patient-reported data. So we have a mobile app where the patient can enter their own bleed information when they have a bleed, the treatment they've taken. They can do questionnaires on their quality of life. And importantly, they can also see these data and follow their own health. The registry also shares these data with the doctors, so the doctors have better, more informed conversations with their patients. And of course, advocacy, one cannot stress that enough. So the data from the registry can be used for that. Next slide, please. So I'd like to share with you a nice story from one of our HTCs in the state of Kerala in India. So this story illustrates the importance of collecting data and to improve diagnosis and identification. And the reason I'll be sharing this story, as I hope you will appreciate, that this is something that can be done for women and girls as well. So this project started with the funding from the WBDR Research Support Program. Next, please. So the state of Kerala has about a projected estimate of over 3,600 people with hemophilia. And the group working on this study, they proposed that the disease is underdiagnosed. Only 900 of these patients are registered at the HTC. Next. So the objectives were to identify more or get as closely as possible to the actual number of people with hemophilia in Kerala, and to collect more data and accurate data at that on these patients. And the third objective was to advocate for better care and treatment. Next. So what they've done is they've organized 8 hemophilia awareness and family screen camps. They had over 600 participants. 531 blood samples were collected and screened. And throughout this initiative, they've identified 61 new people with hemophilia, 39 of which were children. And the WBDR, of course, along the way was used to collect all these data and analyze these data. Next. So the outcomes of this work has been reported to the government of Kerala, including the importance of treating children under the age of 10 with prophylaxis. Another major achievement of this initiative was that they were able to help the health service department to formulate a comprehensive policy for hemophilia care. So this is a fantastic success story that we hope we can replicate elsewhere. And especially it could be an inspiration for us to focus on women and girls' identification and diagnosis. Next slide. So I hope that it was convincing enough that the WBDR can lay the groundwork for data collection on women and girls with bleeding disorders. Next. So through the registry, we can improve identification and accurate diagnosis, as you've seen in the previous example. Real-world data on women and girls will show the clinical experience and the impact and the scale of the bleeding disorder. Research, again, the 4 R's. Research is the last R, but it's ultimately what will bring more treatment. And research will need reliable data from our registry, and what will help improve the clinical management related to female-specific challenges. And advocacy. I think education, awareness campaigns are essential, and they can be evidence-based using the data from the registry. And the last next, I would like to leave you with one message. I think we can all agree that we need less stigma and more access. Thank you.
Thank you, Emily, so much. I loved the example of Kerala. That is incredible, the outcomes of just 1 year. So that's really exciting. Thank you so much for sharing that. Next up, I'd like to welcome our 2 panelists, Dr. Elizabeth Pampour from Latvia and Anne-Louise Cruikshank from South Africa, who will introduce themselves, but they're going to be discussing some case studies on getting access and the importance of various roles in women and girls with bleeding disorders healthcare. Welcome to you both, and take it away.
Hello, everyone. It's a great honor to be here. And when I was invited to talk about my role as obstetrician and gynecologist, I always think and I try to inspire my colleagues by my own examples. And in the next slide, I would like to show the most frequent situations. So the next slide, which I have encountered in my practice when I was working in emergency department. And what I think are the most suspicious situations are recurrent bleeding episodes that require women to come to emergency help. It might be severe menstrual bleeding. It also might be severe bleeding in abdominal cavity after ovulation, or we call it hemorrhagic cyst. As you can see in the picture, there is a cycle of the ovary. And when the oocyte in the ovulation is liberated, it might rupture the capsule of the ovary. And if in this case there is blood vessel, it might cause bleeding. Normally, the bleeding is self-limited, but in case there is some problems with the factors or some problems with hemostasis, this bleeding is unstoppable, and it happens that there is a lot of blood in abdominal cavity. In case this is once per lifetime, it might be okay, but if this happens many times, I'm very, very suspicious, and I might refer this patient to hematologist. And again, postpartum bleeding, we are taught in school that there are 4 T's that might cause this bleeding. It's trauma, for example, some ruptures, which we suture. Then there is the atony of the uterus. Then we use medication that makes it toned, the uterus, and of course tissue in case there is some retained placenta. And in rare cases, only 1% this thrombophilia or some problems with hemostasis. And actually now, when I don't see these 3 most common causes, I also refer patients to hematologists. I wrote this in their postpartum document, and I think this is a good practice. In the next slide, I need to warn you that there is a picture of, there is a picture with one of my patients. This was the situation I showed you with the ovary. There was this bleeding from ovulation site, and the surgeons decided to do laparoscopy to evacuate the blood. And it was very interesting that after 12 hours, we see this dressing in the umbilicus with a lot of blood, no blood clots. And of course, the first thought was that maybe surgeon didn't suture good enough. But actually, in this case, there usually is no blood. We can close the wound with simple suture, and it's not bleeding like this. I referred the patient to hematologist, and it turned out she has hemophilia B. So this is also a warning situation in my practice. My colleague Anne-Louise from South Africa will continue with her stories.
Hi, good afternoon, everybody. I can't put my video on, so if you can, it says you've stopped my video, so I don't know if you can from your side. So I just wanted to just share with you, I basically work in Hemophilia Treatment Center, but I'm very privileged because I look after women and men with bleeding disorders, and I manage both in comprehensive care centers. And actually I do get referrals, but I think probably the biggest way that we do get the patients is probably from actually family histories and speaking to the patients themselves. So I wanted to just share with you 2 cases that I have had in the past. If I can have the next slide, please. So the first one was a 51-year-old lady. Now she's 51. She had no history of bleeding in the family at all. She had a son that was born in a private clinic in about 2001. And she was fine. The baby was fine. The baby did have some bleeding issues and some bruising, but nobody actually worried about it terribly much, and she wasn't referred, or she didn't go to the pediatrician. And then when she went back and she was pregnant with her second child, after taking a really good history, the gynecologist who saw her, the obstetrician, said, you know, this really doesn't look good, because, you know, you didn't heal after your cesarean section. And also asked her, did she have any children? And she, you know, she said, how was the son? And then she actually admitted that he bled after circumcision. So fortunately, he sent her off to the hematologist. He did factor VIII levels on her, and they actually diagnosed her son at about 7 months with severe hemophilia. And if he hadn't picked that up in the very beginning, we may never have known for a little while longer. She subsequently had a daughter, and she's well now, but she's basically also a symptomatic carrier. She's needed clotting factor concentrates for all her surgeries, and she's been well managed now because people know about her, and we're aware of her condition. So this actually was something that happened in the community and was referred to us when she had her son. So she is managed now in the Women with Bleeding Disorders Clinic. And the next slide, please. And this was also a lady with actually von Willebrand's disease. She was diagnosed originally as a moderate von Willebrand's. And I think the other thing we have to bear in mind is if patients were tested very long ago, the tests in the lab is not as accurate as they are today. And she was sort of diagnosed as a moderate. And in those days, they didn't do multimers or anything, so we didn't have typing either. And then she was referred to us, and we noticed that she had actually an increase in bleeds and a very low iron over time. So we retested her in 2012 and discovered that she was actually a severe patient with a bleeding disorder, with von Willebrand's disease. So what we did, because due to her low iron levels and she was starting to have joint bleeds as well, she was started on prophylaxis at the age of 33. For heavy menstrual bleeding, she had a Mirena inserted. Since then, her quality of life has improved no end with very little bleeding. She also recently, she actually fell in the shower, and she'd obviously been giving her prophylaxis during the week, and she was very bruised, but she made her husband bring the clotting factor concentrate to the shower. She gave a dose of clotting factor, came to us, and she actually made a very quick recovery, because then she was aware, she knew what the problems were, and she had the clotting factor concentrate at home. So I think really it's very important about the relationship with the patients too, that they contact you and you know what their problems are, what the issues are, and how to help them, and maintain that relationship over a very long period of time. So those are my two cases. Thank you.
Thank you both so much. So we are going to ask all of our panelists to come, all of our speakers today and panelists to come on screen. So please turn on your cameras. For people in the audience, I already do have some questions loaded. I see we've got 6 questions. We're going to go to the audience questions first, because I want to make sure your questions are answered before we go to some of the other questions I've been writing down. So let's go ahead and go to the next. Let's see. Oh, we do have another slide, but I think we want to stay here. Is it possible for us to see everyone on screen? Yes, thank you so much. That's actually perfect. So everyone, just thank you so much for your presentations today. We have a really lovely list of questions. So the first one I want to ask, it was during Dr. Lavin's presentation, but I think that we've got our panelists here that can tackle this. The question was, is the pictorial blood assessment chart a fairly useful way to assess the extent of menstruation? Dr. Kulkarni, Dr. Pampour, do you have thoughts about that?
So yes, can you guys hear me?
Yes.
Okay, so the PBAC, as we call it, or pictorial blood assessment chart, is something that we routinely do in our clinics for all women and girls. And we keep a track, and actually at the study that we published, the CDC study on the use of tranexamic acid versus DDAVP in women and girls over the age of 18, we showed, Peter Quides was the first author of the article, and I was a co-author, and we showed that the PBAC scores, there's a certain score, like you've got to get so many points that shows heavy menstrual bleeding, decreased when you used tranexamic acid more than when you used DDAVP. It was a crossover study. And we use it all the time to see. The only thing we haven't done regularly is that over time, what happens? Is your treatment effective? Mm-hmm. You would expect it to be this thing. And I wish there'd be more study showing the impact of various treatments on PBAC over time.
Thank you very much. Another question came in, which I think is a really good question. I think this comes up a lot if you have any physician who doesn't work with women and girls with bleeding disorders. Why do we need to follow cases where there's normal factor level? So for example, I even saw in the case study that Anne-Louise just shared, there was a woman with 43% levels, but had significant bleeding. And so, in that case, if you think about it, somebody may dismiss that and say, oh, don't worry about this. You have normal levels. You shouldn't be having these issues. So what is the benefit? And then how, as a woman with bleeding disorder, how do you advocate for going beyond the percentage?
So I can address that. It's actually a very well-known fact that hemophilia carriers bleed with much higher levels of factor 8 or 9 than normal people. And so that's why, we lobbied the International Society for Thrombosis Hemostasis to not have a men's normal level equivalent to a woman. So there are symptomatic carriers. That means they have levels which are normal, but they're symptomatic. And I think there's currently a lot of interest of bleeding of unknown cause. These are called BUCs or BDUCs. That means, it's just not there are so many factors involved in bleeding, including platelets. It's very difficult to study platelets, especially in remote areas and all that. And that's an important cause for bleeding. And I think there's a lot of, I would say, research now being focused. And the uterus in itself is different in terms of its bleeding. Some women bleed, others don't. And again, with von Willebrand's disease, some of the levels go up with age. Mm-hmm. There is some recent data to show that may also happen with hemophilia carriers. Dr. Neeraja Swaminathan has actually submitted an abstract about the, history of carrier, but those are areas I think ripe for study. So if somebody thinks there's nothing to study in women and girls, oh my God, just come on over and study them. And we need to understand this so we can, again,
I think Dr. Lowen pointed that out too in her presentation. One of the 4 R's was a needed research. Absolutely. Emily, this question is for you. Does the WBDR allow for registration of all of the categories of women with hemophilia? And I would also add, this is an aside, but other bleeding disorders. But this was according to the 2021 ISTH publication.
Yes, so WFH has adopted that definition of the ISTH SSC group. So just a quick definition of that. So hemophilia carriers are categorized as, if they have lower levels than 40%, as women and girls with mild or moderate or severe hemophilia. But as Roshni mentioned, even if they have above 40%, they are considered carriers, and there are 2 groups, symptomatic and asymptomatic. Mm-hmm. So every woman and girl that comes into the HTC, we believe likely to have symptoms. And even if not, she's coming for consult, for genetic testing, they can all be registered in the WBDR. There's no category that says women and girl. We all consider them, hemophilia patients, correct? So we don't want to have this segregation of our patients. So they are called the same way we would call a man with mild, moderate, or severe hemophilia. At the moment, there's no category for asymptomatic carrier, but I think that came from Dr. Kudzi, but we can discuss this further if this is something that we can add or discuss in the future for sure.
Wonderful. Thank you so much. So what could be done to encourage the investigation and recording of hemophilic complications such as arthropathy in women? Women are regularly told that they don't have joint bleeds, but in the Probe Australian study, and this came from Suzanne O'Callaghan, it's great to see you here, Suzanne, they found that 52% of women with hemophilia reported arthritis and 29% of women with also reported that without a bleeding disorder. It raised the question of whether this is osteoarthritis or hemophilic arthropathy. And the age category was women aged 45 plus. I don't know who can answer that, but I'd love to hear your perspectives.
So I can address that a little bit. So I've seen women, and believe me, they do have arthropathy. They have, I mean, is this because of, microbleeds, so-called, or lower factor? Again, this is an area, I mean, would administration of factor or administration of, the therapies that we use for men be effective? That needs to be studied. And I think that is a plea I make to the pharmaceutical companies and people who do clinical research and trials, that please study these women. Maybe we need to do their joint assessment starting from a young age and seeing whether that decreases. Is there any relationship to factor level? Would administration of factor improve it? Have half of them on some prophy and other half of, watch them. I mean, we got to start with what we did in men years ago, but we have learned from men. So I think we can start a little bit better and do it better. Yes, I do believe women get arthropathy from their bleeding disorder.
Absolutely. Thank you so much. Elizabeth and Anne-Louise, I'm sorry. I would like to ask you both this question because I think you come to this from a different perspective. And that is the question about how can we encourage and motivate physicians, or I'm going to also say other healthcare professionals or providers who are either not aware of bleeding disorders or just firmly think that the heavy bleeding is normal, and to get them to actually test women and refer to hematology. And this is in particular to heavy menses for potential bleeding disorder. What thoughts do you have?
I can definitely say that it's our own as physicians' responsibility, and we have to raise that we are advocates for women's health, especially within obstetricians and gynecologists. I think what really works, it's similar as with cervical cancer, is the story of a woman. I think that works the best, and we can talk about this theoretically, we can show numbers, but stories work very well. At least I think so. It might be, we don't want to hear it sometimes, but how women are suffering. And I also hear a lot of stories in this webinar, which were new for me. And I think that would encourage, and also think out of the box. Maybe your responsibility is not bleeding disorder, but if you see something, just ask a bit more and give suggestion. You don't need to know all the hematology, but the principles, and we all have learned in our med schools and nursing schools about bruises and epistaxis or bleeding from the nose, and just pay attention and educate a woman about these abnormal patterns, and then tell her where to go and where to seek for help. And I'm very happy about the associations and the societies that also work for patients, and sometimes it's easier for women or patients to read their information which is provided. But yeah, I think stories work the best.
Thank you. And Louise, do you have? Yeah.
Yes, Dawn, I think I would definitely agree with Elizabeth, because I think it's really important that they are made aware as well. So when we do family histories and things, we always try and get all the sisters, the moms, the aunts, whoever may be affected in that family, and speak to them all at some stage or another, get them to come to the clinic appointments, even if we see them at the pediatric clinic, and just give them a background. So at least they're made aware. They can then come to a facility where their factor levels can be tested. And then also, I think also very important is for the, as she said, the organizations to raise awareness too. We actually made a pamphlet for this specifically. And the other thing we've done is we now have a genetic telemedicine program going at the moment, where we actually, the carriers that we haven't managed to reach, actually doing basically online Zoom webinars in those small rural clinics with the nurses, and trying to educate them as well. So the message goes out a bit further, and it's not only the people that you see regularly, but the people that you don't often see. We can try and catch them as well and educate them.
Thank you so much. And actually, I feel like there's a really good question in here that follows this up, and it came from Alain Bowman, who's the CEO of WFH, and he was asking, does it make sense to try to partner with endometriosis patient associations or other, because I think there are other associations out there as well. He has heard many similar concerns caused by a different cause. There's bleeding, there's pain, maybe reproductive concerns, and prejudices, of course, are also part of that, you know, the taboos and the cultural impacts. Does it make sense for us as bleeding disorders organizations to partner with these other patient associations? Does anyone have a thought about that?
I can definitely answer that it will really work very good in order to normalize the menstruation and talk about this, because we are still very shy. We still don't want to talk about this. We still think it's normal to suffer, it's normal to bleed. We don't want to show it and talk about it. And I think with these kind of organization, it will be even much more easier to talk about this, because then you are not a menstruation doctor or the one who is right, crazy about bleeding, but this organization, it's much more official. And of course, sometimes these subdivisions, it's not a good choice because it makes it too scattered. Right. Sometimes. But the cooperation is a good way how to work and help. And if it's related to women, I'm very happy.
Exactly. You know, it also, as I was listening to you, I also think that we don't do enough to call out our partners in our Guys with Bleeding Disorders, in our own community. We need to make sure that we're inviting the men and boys to the table and educating them. And we can say things like period and menstruation and my period lasted this long and all of that. We should be able to talk to our own community members and be able to encourage them to be our champions. And I know many of them want to be, they just don't know how to help. And so just a quick side note, we have so many questions, and I know we don't have enough time. We end in 1 minute, but I want to share this. I was a camp director for 10 years. And one of the things is I brought tampons and I brought pads, and I went to the middle school, we call them the middles, the 12 to 14-year-old boys before they get into the older cabins. And I showed them how that works. I used a sink and I put a tampon down and I said, like, watch this as the water drips into this. This is what happens to a tampon. And here's what happens to a pad. And I had them hold them and pass them around because they said, eventually, someday you may choose to be in a relationship with someone and they may have a period and you need to know what this is about. Or you might have daughters, boys with hemophilia. And so that's actually how I just did a hands-on, let's sit down and talk about periods, and hopefully that helped. Let's go to our very last slide.
I just say one thing. Yes, so at the Foundation for Women and Girls with Blood Disorders meeting this week, we're going to have a plenary session on pain in women, and Stacy Mismer, who's a faculty at MSU and is the president of the International Endometriosis Association, has published in New England Journal and many other things, will be there addressing that. So we are trying at a provider level to try to see how we can work with that foundation.
Wonderful. Thank you, Roshni. That's really important. And just as a final note, I know there are questions in there that we didn't get to. We will try to look at those questions and be able to share that via the WFH e-learning resources. And this has been recorded, and I know it will be posted as well. There were lots of questions about treatment. Someone asked, should women or girls with bleeding disorders have access to factor replacement therapy? Absolutely, 100%. That is what we're saying. So I want to just answer that really quickly. But I just want to thank you all. Thank you to our panelists. Thank you to our audience. You know, we really are fueling progress through knowledge and education. I love this slide. Please, you know, in order to support webinars like this, it's free to all of you to attend if you consider making a contribution. I will say the National Hemophilia Foundation in the United States is very proud to support the Women and Girls with Bleeding Disorders program by making donations. So please consider it, and thank you. I can't wait to see you for the next educational session, and I wish you all a great day, evening, and the rest of your week. Thank you.
Thank you.